this, but I think we can get through it together, and hopefully you had some other stuff to supplement. I'm going to talk about type 1 and mostly focus on insulin and use that as a segue to type 2. I know most of you guys aren't going to be specializing in endocrinology, so type 1 management is probably a little bit outside of scope, but it's a good way to talk about insulin anyway. All right, let's just go through some basics here so you guys know about glucose metabolism. I don't think there's anything specific here that's never been talked about in some biology class you've had at some point, or pathophys hopefully talked about this in much more detail than I will, so I'll keep it going. But basically we're trying to get glucose to be used by the body. Essentially what we're doing, we can manipulate this system a lot of different ways with different medications. Just another slide there. Complications. So diabetes has a lot of long-term effects, mostly in the short term, unless you're type 1 and you don't take your insulin or something like that. Acute effects are rare to see, but usually what you're going to have is long-term complications from people who have just chronically high blood sugar, which usually is two different types of macrovascular and microvasculature complications. So things like stroke, TIA, dementia related to uncontrolled diabetes, cardiac effects such as ACS. Oops, I don't have the right slide up here. There you go. And then microvascular stuff. So if you think about like the things you commonly associate diabetic patients with, so pins and needles, feelings in the extremities, worsening eyesight, stuff like that. So if we can manage it appropriately from the get-go, we can hopefully avoid a lot of this. It's very much similar to blood pressure, a lot of the end systems it affects. And then when you add the two together, you think of pushing a lot of extra glucose through a high pressure system. That's going to complicate matters worse. So that's why the two hand in hand they're unfortunately two of the more common conditions in this country, but also two that are really important to manage pretty aggressively from the get-go, so you don't have to worry about the long-term consequences as much anyway. Okay, so let's start with talking about type 1, and again I want to use this as a segue to talk about insulin. Insulin has a role to play in type 2 diabetes, although there's a lot of other options we can do as well. But type 1 diabetes is one of the most chronic diseases affecting children. It's an autoimmune disease. Insulin producing beta cells are slowly destroyed. Your body starts out with a certain number of beta cells, and it takes a while for that to happen. So it takes a while for your immune system to destroy enough where you can actually see some clinically relevant effects. There's some different ideas on how it happens, but no one really knows for sure. There's some speculation whether it's perinatal environment or viral exposure that possibly causes this, but no one really knows. A lot of people will refer to type 1 as insulin-dependent diabetes because you can't manage it any other way. You don't take oral medications for type 1 diabetes. They wouldn't do anything. We're supplementing something the body can't produce by itself. Just in case you're wondering, I like to look at epidemiology stuff just because it's a little interesting to me that there is a pretty big difference if you look at general trends. So like people of Northern European descent tend to have higher incidences than, like, for example, people of Asian descent. I don't know. Again, just nothing to say about that other than I think it's interesting. So again, I'm not going to talk about epidemiology. You can read that on your own if you want. Genetic susceptibility is also kind of interesting because even twins are not entirely always going to be type 1 diabetics, so it's not necessarily 100% genetic guarantee. That's also something that's kind of fun. Fun facts for the day. Okay, all done with fun facts. Let's talk about onset symptoms. These are going to be the same regardless of why your blood sugar is high, whether it's because you have type 1 diabetes or type 2 diabetes. The symptoms are going to be the same, so we can translate this over to type 2 as well. However, the classic onset of a type 1 patient would be polyuria, polydipsia, and weight loss. So they're going to be having excessive production of urine. That's usually your blood glucose gets above 180 or so. You start to urinate more, and that's your body's compensatory mechanism to get rid of some of that glucose. In kids, you might see bedwetting in a child that's been potty trained for a while. That's a common presentation. Polydipsia, excessive thirst. People, again, a natural mechanism to try and dilute out the high concentration of blood sugar. And weight loss, so hypovolemia, increased catabolism, impaired glucose breakdown causes fat and muscle breakdown. Nausea and anorexia can be caused in extreme cases as well. So again, insulin therapy is required for all type 1 diabetic patients. We'll talk about specifically its use and where it fits in algorithms for type 2 diabetes, but it's pretty similar in how we use it as far as the general strategy. So therapy will start diagnosis of disease. Once you're diagnosed with type 1, you have to be on insulin. Goal of therapy, prevent long-term complications. several products are available. There's a lot of different insulins out on the market, and there's actually within the last couple of years several new products to come on the market too, and not necessarily always a new product per se, but a slightly different formulation of it that is more concentrated or has different kinetics. So we see that come up quite a bit too. Insulin's, I don't think I have this on the slide. Insulin's expensive. It's I don't know if you guys have seen some of the, I feel like there's a lot of stuff going on social media, and I don't know if it's just because my friends are all pharmacy nerds and I don't have a life, or if it's other stuff I don't notice, but a lot of the prices of insulin have gone up consistently, despite the fact that, like, for example, Novolog is a short-acting insulin aspart. It's gone up, I think it's like 3 or 4 times what it originally was, despite the fact that the drug hasn't ever changed. And why do you need to make that much more money? And these products are all, insulin's kind of weird. It's pretty much a biologic agent, so it's a large molecule product. It's a long peptide chain, right? So you can't synthesize it like a small molecule drug. But we run into this issue where insulin's been around for a while. It's probably the oldest biologic therapy if you want to look at it like that. And so people come back to the argument of why can't biologics be produced generically, and why can't there be less expensive versions of them? And yes, they're more expensive to make, but the rates at which we see costs go up don't really match that. It's pharmaceutical company greed, potentially. Who knows exactly what it is? But the point is that insulin is really expensive. I think if you guys follow, not trying to be political here, but I follow all my elected representatives, as a good citizen should, right? And Amy Klobuchar is really big on this, and she's posted a lot about, somebody who had to go without their insulin and died. So there's all these cases that are kind of circulating around in the media right now about this, to help lower, as a kind of a stepping stone to say, let's look at this and find a better solution to lower drug costs. And insulin's definitely one of those where, yeah, if you're type 1 and you can't get it and you can't afford it, you're not going to last very long without it. You're going to go into DKA, and if you don't get that treated aggressively soon, you can die from that. And we'll talk about DKA very briefly during this lecture, but I don't want to spend too much time on it. So anyway, that being said, pre-treatment considerations, there's a couple different ways and strategies you can provide people with insulin. The conventional way, which is probably something you can write next to it as saying old way or not really recommended unless you don't really have a better option for the patient, is single or twice daily injections. The problem is it's just not super effective to do this for somebody with type 1. It doesn't mimic endogenous insulin production very well to give somebody a once or twice daily injection. The only time I ever see this done is if somebody has really poor compliance and that's the only thing they could get, or maybe they can only afford regular insulin, which tends to be a little bit cheaper, or insulin NPH tends to be a little bit cheaper too. And I'll come back to this in a minute too, but the different types. But the conventional strategy is what was originally thought to be effective when people first started experimenting with insulin therapy in type 1 diabetes, and it's since gone by the way of the dinosaur for the most part. Intensive therapy usually involves more than 3 injections a day, and it's mimicking physiologic insulin. So the idea is that you have a basal insulin, and then you supplement with mealtime to bolus dosing, which is kind of how your body would respond to consumption of carbohydrates, right? So you have always some sort of amount of insulin available to be used, and then if you eat a meal, you get a burst of insulin immediately once your blood sugar reaches a certain level. So anyway, a lot better outcomes data. Obviously, more injections means possible risks for compliance, just requires more education with the patient. And then you also have risks for hypoglycemia. Every time somebody takes a drug, there's a risk that they might mess something up. So every time you inject yourself with an insulin pen, there's a risk you increase the units too much, or you drew up the wrong amount from the vial, right? There's always that small risk, even no matter how good or compliant your patient is. Weight gain is more likely with an intensive regimen. Insulin has an interesting relationship with causing weight gain, which may or may not be due to the disease or due to the insulin. There's a lot more interesting data in type 2, so we'll come back to that in a little bit. And then also costs. More insulin use, more expense associated with it. Insulin, I say the old way. Most people don't buy insulin in vials anymore. It's sort of the old process. Vials sometimes are cheaper to buy, and they come as larger volumes. So if somebody can get a discount on them, potentially doing it that way, you might see people doing like an old school vial and needle system where they're pulling up the units themselves. Usually what people use now, and most products come packaged in these pens. And these pens have dose counters on them. So you just take the pen, you twist it until you get to the window of however many units you want to get. You inject it, and then you click it, or you put the needle into your subcutaneous tissue, just like you can see this guy doing here. and then you click the base of the pen and it delivers the insulin. So it's a more foolproof plan. You can only give so much with the pen. Usually pens cap out at like 60 or 80. It depends on the product. So, which can be tricky because if you have somebody on a lot of insulin a day, they might have to go with a couple different pen injections to make up their dose. Sometimes that happens with type 2 where you see people on really high insulin doses with type 2. Type 1, not so much. To get to physiologic insulin, you usually don't need insane amounts, but for type 2 people who are really resistant, sometimes you see them doing a couple pen shots a day. Okay, so the different insulin options out there are basal insulin. Basal is also referred to as long-acting insulin. There's 3 different products on the market right now: Glargine, Detamir, and Degludec. Lantus and Levemir, or Glargine and Detamir, have been on the market for quite a while. Lantus has been by far the primary drug of choice, and I'll show you some kinetics on this on the next slide. And then Tresiba is the new one on the market, where people think it's maybe going to be better than Lantus, but it's more expensive at this point. I don't think we have a lot of data to support that, so a lot of people are still on a Lantus regimen. If they've been stable on a Glargine regimen or Lantus regimen, they're probably not going to switch just because the drug companies say Tresiba is better. But Tresiba has some different kinetics. It's a bit longer acting. It's a bit more of a I think as far as like overlap, there's not really any. It lasts almost an entire day without getting any dip in insulin coverage, which Lantus should do too, but sometimes patients respond differently. And again, I'll show you kinetics on this in a second. Intermediate acting, insulin NPH, or I always forget what NPH stands for. It's like something I'm not even going to say Hagoderm. That's what the H part is. I don't know. It's named after somebody, but you can just call it NPH. Regular insulin is a little bit faster acting than NPH. An NPH regimen would be like twice a day, and a regular insulin regimen is usually 3 or 4 times a day. So they're a little bit different. Whereas these ones, Glargine and Degludec, you're giving once a day, and Detamir, you're usually doing twice a day. Sometimes people do twice daily Glargine regimens too. It depends. Kind of bridging the dose that way, and again, we'll talk about that here in a second. Rapid-acting insulin, Aspart, Lispro, and Glulisine. There's no real difference between the 3 of these. They all work pretty much the same way, so those are kind of easy to remember as one group. And concentration, generally, most insulins come as 100 units per mil, but there are some products starting to vary out there, and I'll show you some examples of those here in a couple slides. So as far as insulin pharmacokinetics go, you've got your endogenous insulin comparing here. So this would be a non-diabetic patient, and you get it senses blood sugar, wants to give you some insulin, your pancreas shoots out some insulin, and then it rapidly gets metabolized that way. It's basically immediately bioavailable, right? It's already in the bloodstream. Whereas everything else gets injected subcutaneously, so it takes a little bit of time for it to absorb and get through all the tissues, and that's where you see these delayed peaks compared to endogenous. Talk about IV insulin very briefly. You can give a regular insulin IV for emergency situations, but kind of outside the scope of this conversation. So anyway, you've got a couple different options here. So you can see like a short-acting regular insulin, which is basically a physiologic or a mimic of physiologic insulin. It should be the exact same structure as physiologic insulin, regular insulin. So you see the subcutaneous, again, is going to delay the absorption. You're not going to get quite as high of a peak, and then you get sort of 4 or 6 hours or so of activity out of it. A long-acting insulin like Glargine or Detamir, they're going to come on much slower, but once you get up to, they don't really have a peak. Detamir is going to have a little bit more of a peak effect, whereas Glargine is going to be really flat the whole time. It never really hits a peak. It leaches very slowly out of the subcutaneous tissue, and it lasts a while once it gets into circulation. So that's why Glargine or Lantus products have been really popular over the years. This is a slide that I'm not going to test you on, other than I want you to know the general groupings of them, but I don't care if you know like down to the minute. It doesn't really matter to me. But I get this question a lot. If you go into emergency medicine or urgent care, this is a really common thing people do accidentally, is they give themselves too much insulin. And so if they come in, you want to know how long you have to watch them. It depends on what insulin they took, right? So this will give you some of the effects. You can find all this stuff online too. But it's a nice way to look at it all as one chunk of information and see the general duration. So you can see, like I was talking about long-acting with Lantus and Levemir having different properties. Lantus or Glargine products tend to have a pretty consistent 24-hour duration. And then Detamir can really depend on the person, so you get really variable and dose-dependent relationships. Higher doses tend to leach out slower from the subcutaneous tissue and almost have a depot effect, which lasts longer. but Glargine just doesn't seem to be restricted by some of those kinetic differences, which makes it a bit of a better option. But people still do take Levemir here and there. And the pricing data, I have no idea if any of this is accurate anymore. It's kind of an old chart, but the kinetics are still the same. I'll talk about combo products here in a second. There are some combination products on the market that have like NPH regular insulin or short-acting insulin with regular insulin, like that, giving you some flexibility here. It gets a little complicated when you throw those into the equation, though. Let's take a step back and talk about basal insulin. So Glargine is preferred for most patients. It's going to be the most common one you're going to see at this point in time, and it's got a very nice onset, very limited peak, and very long lasting. It's predictable as well, and people are really familiar with using it. The products on the market, brand name Lantus is the first one that came out. It's been the longest one, or longest use one. Toujeo is a new product out that's essentially just a Glargine product. It's a U300, and what that means is that a U100 products are 100 units per milliliter, and most pens have 3 mils of product in them. So a pen is basically 300 units for the average insulin. U300 means it's 300 units per milliliter. Where this gets tricky is if the patient tells you they're taking a certain amount of volume, or just be really careful with your units and know which product you're looking at, because you can make mistakes with this really easily if you are prescribing something and they don't understand the unit to unit conversion. Now with pens, it eliminates it. If somebody's drawing up their own insulin, much higher risk. If it's a pen, they're just going up to the units they're prescribed, right? So it shouldn't really be a big deal, but concentrated insulin makes people nervous just because it's concentrated. It's easier for a mistake in some cases. Basaglar, I put on here. This is a newer product that is basically kind of like a Lantus analog. It's made by the same company that makes Humalog. So Humalog is one of the other short-acting insulins we've had on the market for a while, and it's I think Novo Nordisk makes Lantus. It's their biggest competitor in the insulin market, and they came out with Basaglar, which is Glargine, and it's a little bit cheaper. In fact, we were just looking at a cost analysis of this, and based on how much money we spend on Lantus a year, it's our formulary insulin at Allina, we'd save like almost $500,000 if we switched to the Basaglar product alone. So it is a little bit cheaper, but when you extrapolate over a whole health system, it makes a big difference as how much money you can save. So there are some slightly less expensive options, and I'm all about competition. The more products on the market, the lower these prices will get. So hopefully we'll see maybe some other people jump in the game. And I think this is partially due to some of the new laws that have gone into place in the last few years supporting biosimilar products. So they can't be bioidentical to the original biologic agent, but it can be similar enough that you can make a product like that. So that's, I think, what we're seeing with some of these. So maybe we'll see some other companies get into this biosimilar game and help drive some of these costs down. But until then, they're both still quite expensive. Again, about a 24-hour duration for Glargine, and some patients will report it lower, and you'll see this dose twice daily. Sometimes I see the twice daily as an advantage if somebody's taking a lot. So if you're on like 150 units of Glargine total a day, which is a decent amount, but it's not totally unheard of, taking it in 2 separate amounts so that you don't have to do multiple pen injections at one point might be advantageous for people. And then some people think that there is like a drop with Glargine after. If you take it in the morning, maybe like around the 18-hour mark, you might get a drop with Glargine where all of a sudden it's not in your system anymore, so which can cause variations in blood glucose that you don't want. Degludec, is Tresiba, which is the new product. Comes as a U100 and a U200 pen, so there's 2 different concentrations. Again, make sure you're knowing which one you're prescribing, or if your patient's got one or the other, if you're looking at what they're using. It's got about a 25-hour half-life, so slightly longer, and it's got a lower nocturnal hypoglycemia reported. So with some people, when they take a Glargine product, they take it at night or in the evening, they might see a subtle peak with that. Now, it's not really supposed to have much of a peak in the bloodstream, but if it does, it can cause a slight dip in blood sugar. And so people think that Degludec is a little bit flatter even than Glargine, and it's shown clinically to have lower nocturnal hypoglycemia reported, which is why people think Glargine has some issues with it. So you might see that gain some traction at this point. It's definitely a product that's being used pretty frequently, but I wouldn't say it's, I mean, maybe like, I don't know, for every 5 patients that come in, one of them's on Tresiba and the others are all on Lantus. So it's still not super common, but it is gaining some ground. And then Detamir, dose-dependent duration, inconsistent kinetics. It's an option. I don't think it's substantially cheaper than any of the other ones. So if your patient's stable on it, great, but I wouldn't necessarily recommend starting somebody on that. Mealtime insulin or fast-acting insulin, glulisine, aspart, and Lispro, again, they're all basically the same as far as their kinetics go. Insurance will pay for one, and that's the one you're going to pick. This will be the mealtime insulin of choice. Humalog comes as a U100 and a U200. Otherwise, they're all U100 products. Onset's about 0.2 to 0.3 hours, peaks in about an hour to, and then duration maybe 3 to 5 hours, something like that. So again, fairly short acting. And then some other stuff, NPH regimen, regular insulin. Again, NPH is usually dosed BID. Regular insulin is 3 to 4 times a day. Regular insulin is the really tricky one when it comes to concentrations. And I'll say this because U500 insulin is really dangerous and it's highly restricted as to how you use it. We do see patients on U500 every once in a while. So that's a 500 unit per mil concentration. You can just imagine and that comes as a vial. So they do make pens now actually of that, which is probably the best way to do it. But if you have to give somebody a vial, sometimes we see this done. So if you can imagine a patient who's just on, again, we're talking more about type 2 diabetic patients here. Usually type 1 patients don't get into the point where they're on multiple hundreds of units of insulin a day. But if you have a type 2 patient who's really resistant, is on a lot of units a day, can't afford maybe a standard regimen, so they're on a regular regimen, sometimes they'll go to U500. Just make sure, again, everything's very spelled out. The biggest problem I see with that is you'll see people using a regular insulin syringe. So insulin syringes, if you're drawing it up from the vial, are designed for units. So they're in unit gradients instead of milliliters so that people don't have to do the conversion in their head. So if somebody uses a U100 insulin syringe to draw out of a U500 vial, they might tell you, oh, I take 10 units of insulin a day, when actually they're taking 50 because it's 5 times concentrated. We try to get around that. We try to avoid that and have people use U500 syringes specifically for that reason. It's really complicated. But it never fails me. I mean, people will come, usually you end up underdosing the patients, so it's not a big deal if you mess it up. But like people will come into the hospital and they'll say, yeah, I'm on 25 units of U500 3 times a day. I'm like, 25 units of U500 is like impossible to drop. It's a tiny amount. I mean, you think 500 units per mil, it's like, can you do that accurately, really? It's really challenging. So there's probably some kind of a mistake there. So I just double check that. If you run across U500, just one of those drugs you don't see very often, and if you work in hospital care or any type of diabetic care, you'll see it occasionally. You might see it on a primary care basis too. But if you're ever looking at a regimen or reordering that for inpatient stay or anything like that, just make sure that it's a good one to always double check and talk to the patient about. The more people that ask about it, or get a diabetic educator involved or a diabetic specialist involved. In fact, I think our hospital policy is our diabetic person. We only have like one for all of Abbott, which is weird because we're a big hospital. But she'll get involved in every U500 case just as a fail-safe safeguard to make sure that everything's being done appropriately. Okay. Mixed combinations, Novolin, Humulin is 70-30 mix, is 70% NPH, 30% regular. Novolog is 70-30 aspart protamine, which is a little bit longer of a duration longer duration aspart. And aspart protamine itself doesn't come as a solo product, so it's only available in this weird mix thing. And then there's some other Humalog mixes, and there's a Degludec mix, which is an aspart product. So the new Tresiba product comes as Rhizodeg, which is combining it with a mealtime insulin as well. Why you do that, I'm not entirely sure. If you wanted to spread it all out, maybe. But just to go back to the kinetics quick. These are like the mixes here. Oops, there we go. In the red. So you get a peak, and then you kind of have another little bit of a peak too as the longer acting sort of starts to kick in. So your rapid looks pretty much like a rapid insulin, and the rest trails off. So sometimes it's nice if you wanted to give somebody just 3 injections a day and keep the long acting going around the clock, but you're still probably going to end up with an evening gap in coverage of insulin. Well, not super common. All right. So talking about our type 1 diabetic patients, and I don't want to test you on any weight-based dosing or anything crazy like that, so you can sort of just listen for this thing other than to know that when you design an insulin regimen, it starts out weight-based. So people usually look at a total insulin daily dose, and you calculate it weight-based, 0.2 to 0.4 units per kilo per day. And usually patients, like especially teenagers, if that's when they're diagnosed, will need even more. You can adjust the dose daily based on symptoms and blood glucose measurements. So you can make very small adjustments really quickly with insulin. It's one of the nice advantages to insulin. It doesn't take a long time to figure out what your regimen is doing or not. You don't have to wait weeks or months to measure A1C levels or anything like that. You can look at the blood glucose in real time. Nice advantage of managing type 1 patients versus type 2 patients. But anyway, one dose is going to be given, or half the dose of that total weight-based is going to be given as basal insulin, and then usually one time a day, split it in half if you're using Detamir, and then usually given at bedtime or in the morning. And the remaining will be divided up for mealtime. And that's pretty much the standard, and then you can always adjust it after that. For mealtime insulin, this would apply for type 1 or type 2 patients, depending on if they're on insulin. But usually you see a couple different strategies tried for mealtime. There's some that are obviously better than others, but of course it depends on how your patient's doing with a more complicated regimen. Not everyone can do carb counting and sliding scales. It's just not going to work for every patient you come across. So sliding scales are really common. Here's my example of one. This is like a common low-dose sliding scale you'd see in a hospitalized patient who's at risk for hyperglycemia. So if they're slightly above, or they're maybe like pre-diabetic or something like that, this is something we'd order on them. Or if you have a patient who's maybe not doing so well with their oral regimen of type 2, they're on a couple drugs like metformin and maybe a couple others, you want to add sliding scale to their mealtime. This might be something you look at doing. So a fixed dose is something as well. If somebody eats pretty consistently or they've been doing fixed dosing and it's been working, you will see people doing fixed doses with mealtime insulin. It's not ideal because is your meal always going to be the exact same amount of carbohydrates? No, but it is what it is. Carb counting, usually the common carb counting is 3 units per carbohydrate choice. Again, this takes education from a dietitian, so there's some extra steps here that you have to go through. I mean, any diabetic patient should meet with a dietitian probably regardless, but I think it's important really for this carb counting concept to have a number of people involved to educate them appropriately on how to do that, because it does make it more complicated. Fixed plus sliding scale. Some people might be on a base 10 units for every meal, and then they might have a sliding scale like this. So it might say, you know, your base is going to be 10 regardless, but if you are 200, you're going to add 1 unit onto that. So you do 11 units total. So that's something that we see done a lot. Carb counting plus sliding scale, again, kind of like the fixed plus sliding scale, but a little bit more flexible there. And again, patient ability is going to weigh into this a lot. I think the carb plus sliding scale is probably the most advanced one on there, but it's going to give you the best real-time ability to dose the insulin correctly for mealtime insulin, in my opinion. Okay, what about blood glucose monitoring? There's a lot of different systems out there. They all basically do the same thing. They're relatively inexpensive. A lot of companies make their money off test strips, not the actual machines. And a lot of times the patients can get the machine for free or with a discounted coupon or something like that. Insurance pays for pretty much everything. There's a lot of cool technology out there now too. I mean, I don't know if people even really use. I mean, I know people do use test monitors because putting that type of assay into a phone is not really within the realm of technology currently, but doesn't mean they can't Bluetooth connect to your phone. And a lot of them are doing that, and they can communicate it wirelessly to an app on your phone that downloads all your data. Come in and have a visit with their provider. They show them all their readings and everything like that. You can see all their trends, and it's a nice system that way. Have you guys ever seen the ones that people just wear for a little while? They work. Have you guys somebody come in and demonstrate those at all? No. They're pretty cool. This guy I work with has one, and it's like this little patch thing almost. It's a little bit thicker, and he wears it on his arm, and then he can just take his phone up to it, and it's like an RFID or whatever that technology is anyway. Scans it, and then it automatically reads his blood sugar. And I can't remember how long you can wear it for, but it's a decent amount of time. Definitely more expensive than traditional test strips, but it's pretty cool if your patient can afford it or if their insurance pays for it, because they can gather a lot of real-time data with that. And they could think about it waking up in the middle of the night. If they feel like they're jittery or something, they just simply wave their phone against the thing and it automatically communicates. Some of them now can automatically communicate at certain intervals too as well. So again, lots of cool technology when it comes to this. And I think we're only going to see that type of wearable diabetic technology increase, especially with implantable devices and things like that, are going to really improve the lives of diabetic patients. So testing 4 to 7 times daily, pricking your finger, getting blood samples hopefully is maybe going to be a thing of the past within the next 5-10 years, I would hope, but we'll see what happens. And then we measure blood glucose is great, again, for your type 1 diabetic patients. It's really just a single snapshot into what's going on for a type 2 patient, right? We always look at the hemoglobin A1C for those patients. For type 1 patients, we don't really care about their A1C. We're trying to make sure they have insulin so that they can live. We don't really care that their blood sugar is chronically high, right? We're treating two very different diseases. And I'll talk about A1C levels and all that stuff again in a second here. Let's talk about insulin pumps quickly, just because that's another big area of research and development. And I mean, these have been around for a while, but again, I think these are getting a lot cooler and better as time goes on. And interestingly enough, with different technology out there, has anybody heard about people like hacking their insulin pumps and making them into kind of like an artificial pancreas? Yeah, it's like, yes, people buy the old Medtronic pumps and like hack the Bluetooth code or something. It's pretty ingenious, I think, but also a little bit scary. And it just shows you that technology in our world moves faster than the FDA can approve a device. It's not like Medtronic hasn't thought of that, right? They're or whatever pump company, insert XYZ there, but they figured that out. But you have to get that device approved through the FDA before you can just put it on the market, right? So that's where some of this stuff lags what's actually happening in research and development. People say, well, theoretically it should work just fine, so I'm going to do it myself. And so you have these concepts where you have like a sensor, like I was just talking about, that communicates with the pump directly, and the pump will put in infusion guidelines and adjust it based on what that sensor is doing. Whereas right now, most of the pumps will have they might have a sensor communication that will detect things, but you have to do some manual programming. It will automatically make those changes for you. And there's some safeguards there too. I had a patient coming in to the ED. It was like, I don't know, a couple months ago. But anyway, he came in and his blood sugar was like he came in, it was like 60 or 55 or something. He's really hypoglycemic, and he's like, well, my pump told me to give a bump of this, but my pump's kind of old. I think it's out of contract warranty or something like that. And it's like, okay. And then he had this thing on his phone where he had some kind of a wireless communication where it was logging all his stuff, or his pump was logging all and his blood sugar was like 300 overnight. And the doctor I was working with, no offense to him, but he's a great doctor, but he just missed it and he didn't look at that. And so I was like, did you see that his blood sugar was 300 like a few hours ago? This was early in the morning. And he's like, oh, I didn't see that. And then we went, and then we got our diabetic educator on board, and she came in and she's like, that guy's pump is just doing whatever the hell it feels like. It's like, okay, probably not a good idea if your insulin's just continuously doing, giving you boluses that don't make any sense, which is basically what it was doing, kind of trying to slowly kill the patient it was trying to serve, right? So apparently if you let your pumps go out of service, they turn mutinous on you. That was the moral of the story on that one. But it was just an interesting insight into pump technology and all that stuff, which is great if it all works, but if you have some kind of a malfunction and your lives are in the hands of that device, you have to have a lot of fail-safes in the technology to make sure that there's backups to sense when stuff's not right, so that people can intervene appropriately. Just one other thing about pumps, or a couple other things about pumps. Pumps use rapid-acting insulin, as you can see on the slide there. And so your rapid-acting insulin is slowly infused. So you don't inject basal insulin, you just let the rapid-acting go at a really slow rate, and that's your basal, and then you'd bolus rapid on top of that for mealtime. Pump doses require about 20 to 10% less insulin total when you compare it to a traditional, like 3 times a day, 4 times a day regimen. You can adjust it for different times of the day. Pump plus continuous blood glucose monitoring is available. Again, we talked about that a little bit. I think people think about pumps as, oh, they're going to require less, or they're great for people who can't remember to inject their insulin. Pumps really need to be for compliant patients. You have to be on top of it. You have to know how to change the tubing and take care of the pump and do all that kind of stuff. So at the end of the day, it's not for everyone, but they certainly are great options for the people who they work for or who use them. All right, hypoglycemia, usually blood sugar under 70. Insulin carries the highest risk of any if you think about all our hypoglycemic agents, insulin is going to be the largest risk as far as causing hypoglycemia. It'll directly cause that if you give too much of it, right? That's what it does. Usually people will consume 15 to 20 grams of some sort of simple sugar. There's some products on the market that are special glucose preparations that are designed to absorb really quickly. In severe cases, you can get coma, seizures, and death. If we do get patients in a really bad hypoglycemic response, it's really easy to treat. You just give them IV dextrose, pops back up pretty much instantaneously. So EMS will have that on their rigs, ambulances will have it. And again, your body you can absorb you can absorb simple sugars easily from the oral mucosa too. So even just a little bit of something like a dextrose gel or a dextrose wafer or something like that, if you don't have anything else, juice or candy bar or whatever you have, can help with hypoglycemic patients quite quickly. Glucagon is something some people keep with them. It's a peptide hormone produced by pancreatic alpha cells and endogenously gets released when blood glucose gets low. So it triggers this enzymatic cascade, which results in the release of glucose from glycogen stores. So it's using your body's natural system. There's a synthetic version out there that's just glucagon designed synthetically, and it can be given IM or sub-Q. So some people might carry this kit around with them. The advantage to the glucagon kit is it's very small volume. So to give a glucagon IM, anyone can do it. It's not quite like an EpiPen where it's like all built into one system, but it comes usually as a little vial, and you reconstitute it, and you pull it out, and you can give it. So most people would be competent to do this. When you compare that to IV dextrose, which would be preferred in an emergency case, an IV dextrose amp is like 50 mils of fluid, which you obviously can't give that IM, right? So you have to get an IV access at some point to be able to give that. So that's where, as outpatients, the glucagon emergency kits can have some advantages for people who maybe struggle with hypoglycemic attacks. All right, DKA, again, I don't want to talk about this a ton. Basically, there's different parameters we look at. We give IV insulin at pretty high doses, and it's regular insulin. So you can give a continuous IV insulin infusion. Usually there's a bolus that may or may not be given. It's mostly weight-based as to how much you infuse per hour. And then you monitor their blood glucose continuously. We talked about insulin last fall. It drives potassium into the cells, right? So that's, of course, something you need to be really careful with and watching their potassium, too. Somebody's potassium is really low. Before you want to start IV insulin, you have to replace that first. You don't want to drive their potassium further because then you're going to cause a cardiac arrest on top of the DKA. So that's pretty much it. The only thing I really want you to know about DKA, it's not about DKA specifically, but that you can give regular insulin intravenously. It's the only insulin out there that's studied for that. HHS, or hyperosmolar hyperglycemic state, is little to no keto acid accumulation, but its blood glucose is greater than 1,000. It's usually more associated with type 2 diabetes, so really just untreated type 2. And the treatment's really the same thing. You don't do anything differently. It's just physiologically, it's quite a bit different, but we don't need to go into that. All right, let's take a... I'll take any questions, actually, if you guys have any insulin questions or type 1 questions right now. Yeah.
It's kind of random, but as far as like a lot of the fake sugars that are being put into foods, how does that kind of work? Is it just the same as like if it's a carb, it's a carb?
Yeah, it's got to have some kind of a carbohydrate count. So as far as I know, like synthetic sweeteners generally don't have caloric counts. So I don't know if they don't get absorbed from the GI tract or what. It's a little bit out of my realm. You guys have a dietitian coming in to talk to you at all about some of this stuff? No? Okay. They might be a better person to ask those questions on it, because there might be some sugar substitutes that do have caloric content and might mess that up, but I don't know of any personally.
I talked to the endocrinologist this morning, and she said, on that exact question, she said there's not really.
There's not like a dosing that needs to be like you don't need to worry about substitutes.
Exactly.
Yeah. Yeah, so just regular sugar stuff. Yeah, sucralose seems like it's in almost everything nowadays. A lot of those drinks have it in them. But yeah, it shouldn't absorb really, as far as I know. All right.
I have a question
Yeah.
about the sliding scale.
Yes.
So for that, just about the sequence, I guess. I'm more just curious. So you're taking the fixed dose or the carb count dose, then you're taking the insulin, then you're eating, and then checking the blood sugar again and seeing what sliding scale.
Yeah, pretty much. That's how it works. So usually it's preprandial. Well, there's different ways you can do it, but usually you take it. So you think about prior to a meal, your insulin or your blood sugar should be normal. So if you're looking at this, and maybe you take 10, or you did your carb counting and you did 3 carb choices. So let's say you're doing 9 units, and then you do your blood sugar right before your meal. It comes back 200. You're going to add 1 unit on top of that. And that's going to give you your total for 10 units for that meal. So it's thinking about like a normal person should be normal glycemic preprandial, and then post-meal you're going to see a spike. But if you do a measuring post-meal, some places, some people might manage it that way, where they look and see if they get a really high spike post-prandial, but it's less common than a preprandial measurement. Yes?
I know you said don't worry about the weight-based calculations and such, but with this like, sliding scale or anything like that, or something, I mean, are we gonna have to figure out how many units somebody needs or anything?
No, I won't make you calculate units or anything like that. I might ask you something about like, well, no, I won't ask you anything related to dosing of insulin, so don't really worry about this. I might give you a scenario where a patient's on something like a fixed or sliding scale and ask you like, if that's the most optimal way or something. I don't even know if I have a question about that. I'm just making that up. But that would be more of the conceptual point I'd be getting at versus actually having you do some kind of a regimen.
And then are we sticking still with like the generic names versus brand names?
Yes. Yes, I believe they're all generic names. I think what I did for the exam, and I can double check this with you guys before the actual exam, but I believe all the questions, like for I don't think I asked you anything about these newer ones. I think I just used glargine as my basal insulin, or I use terms like basal or mealtime. I don't necessarily ask you about the specific products. So in mealtime, I think I only use Aspart as my product. So again, but if you know them all, I just know that those, again, fall into that phase, because there might be a question that says, which of these is not a long-acting insulin or something, and then I might put in a question there. But I won't ask you to, like, switch between the two. That makes sense? I might have
kind of like what we've done on other tests where it's like, these are your options for short, these are your options for intermediate, these are options for long.
Yep, exactly. And then when it comes down to, like, a clinical decision-making, it would just be, like, basal insulin would be your choice. So, like, if you're talking about a type 2 diabetic patient, do you want to give them basal insulin, or do you want to try a different oral hypoglycemic agent? We'll talk about that later. All right. Yeah, 5-minute break, and then I'll come finish up for the day. Not very tasteful, but we'll go with it. It's the type 1 versus the type 2 diabetic. You kind of think of like a type 1 patient as being more lean, and generally they don't have a lot of extra adipose tissue. And type 2 patients, they usually got to type 2 because of lifestyle choices here and there. And as far as I know, I'm 99% sure Michael Phelps does not have type 1 diabetes, so don't think I'm saying that. Anyway, so type 2 diabetes, there's a lot of different options that weigh into, or factors I should say, that weigh into either increasing complication risk or putting people at high risk for developing the disease to begin with. So, and they're listed there. And of course, at the end of the day, this is the opposite of what we just talked about. So instead of having insulin to make you, pancreas makes insulin to a certain point, right? At some point in diabetes 2, you get to the point where your pancreas is turning out so much insulin, it's getting rejected by your body because your body is so resistant to it that you end up, or so resistant to using glucose that you end up with pancreatic damage. But that takes a long time to happen. So at the end of the day, muscle resistance, can't take the glucose because you've got insulin resistance going on. All right, sugars causes problems, reduce your risks. There's my infographics of the day. Go swimming. What are these ones? Is there dancing on there? Yep. Brisk walking. Everything's good. Not right now. Don't go swimming now. Just to show you just some stats on glucose resistance and body weight or glucose tolerance and body weight is tolerated, or is correlated with some different studies out there. A little bit more epidemiologic data. So diabetes 2 affects about 8% of the U.S. population. It's a lot of people. 25 to 40% of people probably aren't diagnosed. So there's another several million out there that are walking around with diabetes that have no idea that they have it, or have been told they might have it, or have been told they're pre-diabetic and never really followed up. 90% of diabetics out there are type 2. So again, we're talking about the most common disease, one of the most common diseases in the country here. Fasting labs, normal fasting blood sugar should be less than 100 milligrams per deciliter, and normal A1C, we're going to talk about the guidelines, and some of them are different depending on which one you read, but normal A1C should be about less than 6.5%. Screening criteria, if your A1C is above 6.5%, if your fasting blood sugar is over 126, or 2-hour blood sugar with an oral glucose tolerance test is more than 200 milligrams per deciliter. Usually we just use A1C. That's what all the guidelines are based on. I don't really care about like a snapshot blood sugar. So hemoglobin transports oxygen, and glucose molecules can bind to hemoglobin, which calls it glycolated, or what is that? Glycated hemoglobin. So anyway, that's what your hemoglobin A1C is looking at, in case you guys are wondering what it's actually measuring. It's how much of that glucose is bound to your protein, which in this case is hemoglobin. The guidelines are there are a couple different prominent ones out there. The major ones are the ADA guidelines, and then the AACE, which is basically like the endocrinology college people guidelines, and there are pretty much the same, but you can see they are slightly different, which is not really helpful because they're both accepted as being fairly comprehensive and good guidelines, but they do disagree on some things. And you can see they have drastically different goals. Like, look at the pregnant patient goal. That's a pretty big difference. But other than that, some of the stuff is somewhat the same. I feel like the endocrinology folks are a little bit more aggressive across the board with their goals. But overall, it's not terribly different. Non-pharmacologic options. So to look at treating a type 2 diabetic, non-pharmacologic options are always the first thing you want to look at. So weight reduction, diet, calorie restriction, food choices, carb counting. Set them up with your dietitian in your clinic office or wherever you happen to work. And that's going to be a good step forward for them to have some kind of a contact that can educate them some of the stuff. Now, if you're a certified diabetes educator, or if you feel comfortable with that, certainly you can do that too. But I think dietitians are a great resource, and might as well use them. Exercise. Exercise is proven to improve blood glucose utilization and insulin responsiveness. Now, if you're wondering if people can actually sustain these types of things, or if this is a long-term strategy, the evidence out there would say that that's a little bit disappointing. And I'm sure we've all had anecdotal people tell us who, like, I had an old boss who he was diagnosed with type 2 diabetes, and his first hemoglobin A1C was like 13%. And he cut out a bunch of stuff in his diet, and he never really lost any weight. And he would still eat like onion rings when we'd go out to lunch. But so I don't know. But he somehow, by cutting out, maybe, like, I don't know if he's drinking pop or what exactly, but he said he just cut out all the extra sugar in his diet, and he ended up with hemoglobin A1C below 7 just doing that alone. So again, he's like the only person I've ever heard who's done that. But I'm sure people have heard of anecdotal evidence. But the point is, there's some large trials looking at some of this stuff and whether it's sustainable. And there's this big study in the UK. You can look it up. There's this acronym if you're curious. But it was a low-calorie, low-fat, high-complex carb diet. Achieved 3%, achieved their fasting blood glucose goals. Now, whether that's an appropriate diet or not, we could debate diets back and forth all day, which is why I'm not a dietitian, and thankful I'm not, because everyone has their own opinion on what diet is optimal. And there's lots of fad diets out there that are really weird. But anyway, I'll stop talking about that right now. Compliance with exercise programs per studies just does not last. It can give you short-term gains, same thing with diet, but it's hard for people to sustain the benefits on that. So again, there are people out there that can make those lifestyle changes, and diabetes can be managed with lifestyle modifications. It really can be, especially if you catch it early. But the person has to commit to it and has to be able to sustain it. If their lifestyle is going to drastically change, the bigger the impact they can make, it's going to make a difference. Like kind of what I talked about with the cholesterol lecture. The people who get better results with LDL lowering are the people that have really terrible lifestyle choices to begin with. And if we can modify those, they're going to get substantially better results. Now, if somebody is diabetic and they have an okay lifestyle, and you might want to tweak some things here or there, are you really going to see benefits from that? It's possible, but it really depends on how far they're willing to go. And some patients, you just might not be able to make it work with lifestyle. And again, the studies out there will show that there's not a lot of good evidence to support that. But still, all the guidelines would recommend those lifestyle modification choices that I mentioned as being core therapy for any diabetic patient, type 2 diabetic. All right, let's talk about the drugs. Metformin. Metformin is one of the older drugs used to treat type 2 diabetes, and it's by far it's kind of nice actually, because all the guidelines agree that metformin is still the first choice. So that's one area where they're like, yep, we all still really like metformin. Metformin's mechanism is actually kind of unique to oral hypoglycemic agents. They all have somewhat unique mechanisms, but I'll explain why metformin is as we talk about some of the other ones. But it decreases hepatic glucose production, decreases intestinal absorption of glucose, and increases peripheral glucose uptake and utilization. One important thing to note about this is this does nothing with insulin. It doesn't release insulin. It doesn't promote the the upregulation and production of insulin from the pancreas. It doesn't modify what your body is doing with its insulin, which is why it's a preferred agent. Anytime you mess with insulin, you are going to cause increases in hypoglycemic episodes, and you're also oftentimes going to cause increases in weight gain. So that's why people still love metformin, because it really doesn't touch insulin. At least kind of whatever your body's doing with insulin alone, it augments the way your body processes glucose, which is a great way to approach treating diabetes. Usually you get A1C reduction by about 1.5% on average just by adding metformin alone. It's a first-line therapy for essentially every patient out there with type 2 diabetes. There are some contraindications, so estimated GFR less than 30 mils per minute. This is new. So we've talked about creatinine clearance a lot, and that's the number I always give you. This is actually some new guidelines that came out to talk about metformin that use eGFR as their calculation, which is that MDRD equation I showed you at the beginning with all those weird exponential variables, or exponent variables. But anyway, the point is that less than 30 mils per minute is the cutoff for that, and that's been a new recommendation as a contraindication. There's also a theory that people, when they take metformin and they get IV iodinated contrast media for like a surgical procedure or something, they might be at higher risk for nephrotoxicity. So it's usually held a few days before and after those procedures. So you might see that as a common protocol in different health systems. Send someone in for imaging. Side effects: lactic acidosis. Lactic acidosis is problematic because it's associated with sepsis, dehydration, and hypoxemia. It's really rare, and it's very debatable whether metformin even causes lactic acidosis to begin with. There's no solid evidence that says metformin is strongly linked to this. There's some correlative evidence and possible evidence, but there's a lot of confounding variables with that. Personally, I don't buy it. Again, it's a super rare side effect. It's not a reason not to prescribe metformin. The more common side effect is going to be GI related. So people are going to get diarrhea, possibly nausea and vomiting, or flatulence, about 10 to 50% incidence depending on the study you read. The nice option is metformin comes as an immediate release and an extended release product. I always recommend people, if you're starting on metformin, just start with the ER. It's not less expensive, it's cheap. They're both generic and have been generic for a while. Just start with the extended release. It's going to make their GI symptoms a lot more manageable. They still might have some issues with it, and those issues might normalize over time as the patient takes it, so it's maybe worth sticking with it for a week or so. But definitely try the ER version. I think a lot of people go straight to the twice a day regular release, but there's no reason not to try the ER. It can really help people out with that common side effect. All right, next class of drugs, sulfonylureas. Metformin, by the way, is a drug, and it's kind of its own class. There's nothing like metformin out there. There's no equivalent product to it, so it's kind of interesting. A lot of these other ones have multiples in the classes. So sulfonylureas are a drug that they've actually been around for quite a while. They're sort of the mainstay second-line therapy. However, that's changing, and a lot of the guidelines don't really like these drugs as much as they used to. So we'll talk about some of that controversy here in a second. But sulfonylureas stimulate insulin release from beta cells and reduce glucose output by the liver, and peripheral insulin sensitivity increase. So they are definitely using insulin here, which means they're going to cause hypoglycemia. In fact, out of all the oral agents we have, they're one of the ones most likely to cause hypoglycemic effects. And so it's really important to take these with food. The drugs themselves are quite effective. They have pretty good A1C lowering capabilities, about 1 to 2%. However, they do see that the effectiveness of that decreases over time, so you might gain some of that back. Historically, they've always been the second-line therapy. If you have poor renal function, a lot of times these were the first things people would go to if their metformin is contraindicated. Side effects are hypoglycemia. Again, I said that. Weight gain has been one that's been kind of at the forefront of sulfonylurea controversy lately, is that we don't want our diabetic patients who some of them are already going to be overweight. We don't want them to gain more weight, so why give them a drug that has weight gain as a complication? Increase in beta cell failure as well. There's this theory out there that whenever you give a drug, especially an oral hypoglycemic agent that manipulates insulin, you're going to tax the pancreas over time, and if you do that, you're going to increase your disease, basically, right? The whole homeostasis of your body in producing insulin is getting overly stimulated by sulfonylureas, and yes, in the short term you see effects, but over the long term, people think that that hurts the pancreas too much, and you lose your endogenous ability to pump out insulin by that. So that's not totally proven right now, but that's a big theory in the endocrinology community, is why sulfonylureas are controversial and why they've kind of almost fallen out of favor. Like you'll see that, I'll show you the endocrinology guidelines, and they don't really recommend them until pretty far down. The drugs are, despite the fact that they're falling out of favor, are super common still. I see tons of patients on these. Glipizide, glyburide, and glimepiride are the 3 agents available. Glipizide is probably the most common one. It doesn't require any renal adjustment, which is a nice advantage compared to metformin or compared to its counterparts here. It's short acting, it's twice daily dose, but you can give an extended release formulation. Glyburide is a longer acting once daily. It does require some renal adjustment potentially. They kind of give a soft recommendation that you don't really need it, but should consider it, so I'd probably consider it. Glimepiride or Amaryl is renally adjusted, so that's the big difference, and I just want you to know that glyburide isn't renally adjusted when you're looking at the differences between these agents. Don't worry about extended release or once daily or anything. Technically, they all come as a once daily form. But remember, when you give these, give them with a meal. Regardless of whether it's once daily or twice daily, give it with a meal. It can help limit and buffer some of the hypoglycemic effects you get when you get the peak absorption from the drug. All right, try and say this one fast. Thiazolidinediones are a mechanism of action that's unique, again, like all these medications. There's 2 drugs. Pioglitazone is really the only one on the market anymore, technically. Rosiglitazone was on the market, and then it was removed due to increased risk of myocardial infarction. There was a study that came out saying people who took it had higher rates of MI for some reason, and they reversed it. And the funny thing is they did a lot of extra evidence and studies on this, and the FDA had to reverse that restriction and put it back on the market in 2013. Well, they totally missed the boat because I don't think anyone prescribes it anymore. And pioglitazone, whoever makes Actos, made a killing off that because they were the only product on the market, and still really the only product on the market. Technically, again, Avandia or rosiglitazone is available, but I don't know if the company even makes it anymore because they kind of lost their market share completely. So funny side note. France and Germany have actually removed this drug from their market overall because of a slight increase in bladder cancer risks. The U.S. has not followed suit. France and Germany, from what I understand, the European recommendation is that we don't believe this drug provides enough benefit. There's other good agents out there. We don't need this, so let's not give it. It might cause cancer. Don't worry. Don't waste our time with it. Not a bad theory, but again, there's not a lot of great evidence to support that correlation, but there is some trending that way. Mechanism, it's a PPAR gamma agonist, which means that it activates genes involving glucose and lipid metabolism. It improves target cell response to insulin and doesn't increase insulin secretion. So it doesn't necessarily directly increase insulin secretion, but it does manipulate insulin a little bit. You shouldn't really see, because it doesn't increase insulin secretion, you shouldn't see a ton of hypoglycemic episodes with this. It does have decent A1C lowering effects, but it's a little bit more variable than the other 2 drugs we talked about. So people might not get as great a benefit as this as they would with some of the other agents. Side effects: weight gain, fluid retention, and bone loss. So a 1 patient population we don't like these in are heart failure patients because of the fluid retention. We don't want to increase the risk of exacerbation. It's been shown that heart failure patients are at risk for exacerbation. So that's one population we rule out when it comes to these drugs. But we aren't Europe, we aren't France or Germany, so we still do prescribe these occasionally here. And I'll just be the first one to say I hate the names of these classes. Why can't we have nice things like ACE inhibitors or, I don't know, beta blockers? Antihypertensives have such nice rings to them, but the DPP-4, I mean, who's going to remember that? I mean, I like to call these the gliptins because they all end in gliptin, but they're the DPP-4. DPP-4 is dipeptidyl peptidase 4 enzyme, and it inactivates incretin hormones. So it inhibits that process, which, so you're inhibiting the regulation of glucose homeostasis, and it helps insulin secretion from beta cells. So you are manipulating insulin through a really roundabout mechanism here. These drugs are somewhat newer, but they've actually been around for quite a while. Some of them are newer than others, like Januvia has been around for quite a few years, and I believe it's still I think these are all still brand name. Januvia might be going generic soon. If any of them do, Januvia will be the one that does, or sitagliptin. Modest lowering effects, but they do have a reported good synergy with metformin. So some of the studies have looked into if you combine them with metformin, even right off the bat, it can have a much more pronounced effect than just metformin alone, and even more than just this 4 to 0.6%. So there is maybe some synergy that happens there. Again, hypoglycemic risk is there, lower than a sulfonylurea, but it's still possible. They're pretty well tolerated overall. There's not a lot of side effects to talk about. There was an FDA warning released about joint pain, which was 33 cases over a 7-year period. Not a lot to really put, in my opinion, to put a lot of faith in. For people who did get it, side effects or symptoms started 1 month after starting it and resolved 1 month after stopping the drug. So if somebody does get joint pain on this, just stop it, switch to something else. There was a increase in hospitalizations for a couple of the newer agents, alogliptin and saxagliptin. So there's a warning for heart failure patients as well. So another class that we're a little bit nervous about heart failure. However, the studies haven't shown that sitagliptin, for example, has the same risks. So I believe it's still acceptable to use it in the heart failure population. Linagliptin, we're going to talk about empagliflozin in a second here, but linagliptin has been combined with this. I talked about combination pills with blood pressure. Those are really common. Like hydrochlorothiazide comes in combination with everything. And it's the same thing with diabetes. You'll see a lot of combo products like metformin glipizide. You can buy that in one pill. A lot of these have been combined by different companies as convenience measures for patients because a lot of people were on both of them. So you might see that done just to, it's somewhat of a marketing trick, but it might be convenient for people who have to take, multiple pills a day if they can combine something. Okay. SGLT2 inhibitors, or sodium glucose cotransporter. I think this one is a little bit easier to remember. If you remember the SG part of it, I'm not going to test you on the acronym. I'm not going to give you like a match. Well, a matching section would be easy, right, with acronyms. But I don't really care that you know it per se, but I do want you to be able to recognize like which drugs correspond to them. But I'll give you the abbreviation and what it stands for, if that makes sense. Okay. All right, so these all end in gliflozin. So it's a lot easier to say Invokana. These drugs, I have a lot on this slide because I think they're pretty interesting. They're the newest class we have available to us, and they only came out a couple of years ago. They reduce resorption of filtered glucose. So you actually get about a 200 to 300 calorie loss per day because you're basically peeing out sugar. That's how these drugs work. There's a lot of complications associated with that, but it's a novel mechanism to approach diabetes treatment. You get about a 2 to 3 kilogram weight loss over 6 to 12 months, which is sustainable if you take the drug for 2 years based on our current research. So that's just a pretty cool benefit that not a lot of drugs can say, and especially in the diabetic patient population. It can have some advantages. So it is renally dosed, so you don't recommend it if the GFR is less than 60. And the reason being is your kidneys have to be really well functioning for this drug to even work. If you give it to somebody whose kidneys are crap, it's not going to do anything. It's not going to help their diabetes, so we don't deal with it. There is some recommendations for lower GFRs for some patients, but for most people, you just stick with a standard over 60, so normal. So think about like a younger, healthier diabetic patient. These might be a good option for them. Side effects, mild hypoglycemia has been reported, but nothing really severe. It's really hard to decrease all your blood sugar from urination. Hypovolemia, hypotension, and dehydration. Essentially, it's essentially a diuretic in how it's working, or at least a roundabout diuretic, so that is a possibility. Increases serum creatinine, decreases GFR, so you can get acute kidney injury with these drugs. Again, why we want to limit their role in renal dysfunction. Some LDL increases. Why this happens, I have no idea. Your guess is as good as mine, but that's been seen as a trend with this drug. And then the infectious disease-related ones are pretty interesting. So fungal vaginosis, UTI, plus or minus dysuria, balanitis in men have all been seen. If you think about it, you're urinating out high concentrated sugar urine, so they're opportunistic infections, things that like to eat sugar that maybe naturally live in the genital area on humans tend to overgrow sometimes with these drugs, and they're actually pretty common side effects. So it's something that if your patient was prone to some of this to begin with, or if they got a UTI immediately after starting this, that's probably the reason. What's the balance there? Do you treat one and then you re-prescribe it? I think that'd be a conversation with the patient. Certainly could try, but if it recurs multiple times, I would recommend stopping the agent. Increased bone fractures. So there has been a risk with patients who have osteopenia or osteoporosis of getting increased risk of vertebral fractures, and so they recommend to avoid it in those patients. And a twofold risk of leg-foot amputation. Why? Again, I don't really know. So these drugs have this really weird group of effects that I think is just interesting with them, which is why I'm spending so much time on them. But at the same time, I think there's a lot of momentum behind some of these and some of the guidelines that, oh, they're so great for younger patients. And I kind of agree with that to a certain standpoint, but you have to get around all the side effects at the same time. So take the good with the bad, but these are decent drugs. Their A1C benefit lowering isn't that great. However, there's been some interesting positive mortality benefits and cardiovascular outcomes with these. So we might actually, I wouldn't be surprised if we see these expand at some point to other like heart failure indications or other types of things like that. Just because of that some of that data that's coming out in the last couple of years. So, kind of cool drugs, but definitely have I think a somewhat limited role. And they're all new, they're all expensive. So if insurance pays for it, great, but you might have to get a prior auth to get them prescribed. Glucagon-like peptide or GLP-1 agonists are a nice mixed bag of products that have a number of different delivery mechanisms. These are all injectable. And they're all kind of designed like insulin pens, so they look a little bit like an insulin pen. But what you do is there's short-acting products, and Byetta and this other one, I've never actually seen this drug before, but these were the first ones to come out. They've kind of fallen out of favor for the long-acting ones. The data really supports that the long-acting ones have more benefit for patients. So liraglutide, abiglutide, dulaglutide, and then they came out with an extended release of the original one, the exenatide ER, which is Bydureon. Mechanism: increased glucose-dependent insulin secretion, decreases inappropriate glucagon secretion, and slows gastric emptying and decreases food intake. These are subcutaneous injections. They're small biologic molecules, so they're small peptide chains, which makes them expensive to produce. So these aren't cheap, probably the most expensive out of all the classes we've talked about. Lower A1C, about 0.5 to 1%. Variable dosing schedules. Some are once weekly, some are twice weekly, some are every day. The long-acting ones usually are more than that. Probably seen advertisements for Trulicity out there. It seems to be one of the ones that's being more heavily targeted and marketed lately. Some advantages: they can help with weight loss, actually, despite the fact that they have some insulin manipulation. They seem to have it in check so that it's not causing weight gain like some of the other drugs that do that, like our sulfonylureas. Low risk of hypoglycemia. Liraglutide or Victoza has been studied in cardiovascular patient populations or people with high CV risk, and then maybe shown some long-term mortality benefits. So you can see where some of these companies are going, right? They're like, well, if our drugs are good for diabetes, maybe we can sell them on some other, or maybe we can say, well, yeah, the A1C lowering benefit isn't great, but we reduce mortality risk over 5 years. So there's some of those other angles people are trying to play, and the market's getting crowded, right? We've talked about how many classes of drugs already. It's kind of overwhelming to keep in touch with all this, but all this stuff is getting used, and if you work primary care, especially if you work anything in diabetes, you're going to see all these medications. So it is important to know them, despite the fact that it's a little bit complicated. Side effects: GI is most common, nausea, vomiting, diarrhea. Again, the longer acting products tend to have lower rates of that, but still going to be seen. Some animal models have shown thyroid tumor increase rates, but we haven't really seen that mimicked in humans, so not something we're worried about currently. Okay, meglitinides, repaglinide or Prandin, and nataglinide or Starlex have a mechanism that blocks ATP-dependent potassium channels, I can't speak anymore, facilitates calcium entry into beta cells due to membrane depolarization, and stimulates glucose-dependent insulin release. Another glucose manipulator, or insulin manipulator here. Slightly less effective than sulfonylureas and overall a little bit similar. However, they do have a lower hypoglycemic risk. ADA, for example, recommends these as a sulfonylurea supplement. So yeah, especially if you have erratic meal times and you're getting too much of a hypoglycemic crash on the sulfonylureas. They work very similarly. A lot of times people won't say don't use them together with a sulfonylurea, pick one or the other, but this is the one less likely to cause hypoglycemic, but also slightly less effective at lowering A1C. They're brand only, they're fairly expensive. These drugs I won't test you on. They just don't have a huge role in therapy. Alpha-glucosidase inhibitors. They basically work in the GI tract to delay hydrolysis of your ingested complex carbohydrates, and then therefore you get reduction in postprandial glucose and insulin peaks as a result. They have modest A1C lowering effects, and they are substantially tough on the GI tract. So there's that. With type 2, we can use insulin. So historically, this was reserved for failure or several hypoglycemic agents. No one really touched insulin with type 2 patients. And this is kind of still the practice. I think we swung the opposite direction for a while, where basal insulin was one of the third or fourth line options, and it's still an option that people will go to fairly quickly for type 2. But I think there's been some newer evidence that says giving people insulin is not the best approach to type 2 management if you can avoid it. So to hold off on it and focus on medications that can preserve your beta cell functions better for a longer period of time. Current data supports potentially using earlier and more aggressively, though. So some will say that if your A1C is so high, you really have to start with insulin, because you can't. I mean, your options are, what do you give them? 3 different oral agents to try and lower it. Let's talk about my old boss whose A1C was 13. How do we get that below 6.5% with oral agents? You give them 3. Let's say you get 1% on each one, or maybe 1.5% even. You still aren't quite there. So insulin is the answer there. So some of the guidelines will say, you know what, we like our oral agents, and we like the way that the science is leading us towards some of the benefits they have, but at the same time, if you really have high A1C, insulin might be the best thing to do and to start it quickly. It's a little bit contradictory, right? We don't necessarily like insulin as much as we used to, but in some cases it is the best way to approach it. Treatment strategy is similar to type 1. You're basically doing basal and mealtime, right? And you can move to the strategy incrementally, right? So you don't have to start somebody on a basal mealtime regimen. You can start them on basal. You can start them on just mealtime. Usually what's done is they start them on a low-dose basal insulin and then kind of work their way up from there. That's pretty common for type 2. Okay, let's talk about some of the treatment algorithms that are out there. This is one I pulled from UpToDate. I think I'll give the caveat with this slide that this is an oversimplified version. It doesn't quite match up the guidelines, which is what we're going to talk about in a second. But this is really how diabetes 2 has been managed for quite a while. Basically, at diagnosis, you give them lifestyle and metformin. After that, they were usually adding basal insulin on board to that, or a sulfonylurea. And then at that point, if that didn't work, you're switching to intensive insulin. That was kind of this long-term solution for type 2 diabetes, or treatment pathway we were going by for a lot of time. Now, ignore this stuff down here because they call it less well validated than it is. Well, let's look at the actual guidelines and what they recommend here. I pulled this, by the way, out of a pharmacology review packet. So this was somebody else's summary of this, but I think it's really nicely laid out. It shows you how kind of complicated this is. There's not a lot of great answers for this. I mean, you see, you don't have option 1, 2, 3, and 4 here. You have options all in the same tier of which one you pick. So what they'll say, this is ADAs, by the way. ADA says counsel patients on healthy eating, initiate patients on metformin. So again, metformin is always our first one. Lifestyle is always our first choice. Those two things go together. If the A1C is not achieved after 3 months, we want to add a second agent depending on multiple factors and consider initiating therapy at this stage if the A1C is greater than 9. So if the A1C is greater than or equal to 9, you would get 2 agents right away. So you're still going to get metformin, you're still going to do your lifestyle, but you're going to go straight to that. If the A1C is, let's say, 8, start with metformin, then you don't get to your goal with just metformin, then you would add one of these on. And ADA is taking the approach that says, you know, all these drugs have advantages in certain situations, which is probably the smart way to do it. The endocrine people, and I'll show you their slide in a second, a little bit more particular about how they want you to approach it, which is in some cases nice. It's a bit more prescriptive, whereas ADA is sort of like, you know what, these have different uses in different patient populations. So again, is your patient young and healthy and has good kidneys? Maybe you want a SLGT too. Maybe your patient needs some weight loss, so the SLGTs make sense, or the GLPs make sense. Maybe, I don't know, you're traditional, you've had great luck with sulfonylureas and you want to try that. There's not really a right or wrong answer here. All of them have good evidence for different patient populations. We want to make sure, and what I'll try and focus on the test is teasing out some of those details, like those contraindications for heart failure patients. I'll definitely give you a heart failure patient that's diabetic and want you to know some of those ones that are contraindicated to those classes that we have problems with. I want you to know some of the side effects, like the UTI stuff with SLGT2 is the weight loss component, which is a positive thing. hypoglycemic episodes of sulfonylureas. Those are the things that I'll try and focus on for my cases. I'll try and give you, because again, I can't really test you on something like this from a treatment standpoint because there's a number of right pathways. I'll hopefully give you enough information where the choice is clear on which one you're going to pick based on side effects or previous experiences or things like that. Okay, so let's say you have them on 2 agents now, so you picked one of those. You've got metformin. A1C not achieved after 3 months. You want to add a 3rd agent depending on patient-specific factors and drug characteristics. That's going to be this series. So then they're giving you a bit more of a prescriptive algorithm here. So let's say you did metformin plus a sulfonylurea. Well, this is where they say you should go, and it's kind of in order of what they think you should prescribe there. So they're getting a little bit more detailed with this slide. And again, this gets into the weeds. You can mix and match a lot of these. So they actually like sulfonylureas. As you can see, a lot of these cases, depending on what you prescribe, they'd recommend them as 3rd line, which is going to contrast with endocrine. So anyway, a lot of this is based on synergy and things like that, where they think you'd make the most sense to combine drugs. And interestingly enough, they put the GLPs like at the very bottom, which is kind of funny, or close to the bottom in a lot of these, and we'll see endocrine does it almost flipped. So if A1C is not achieved after 3 months, patient is on an oral combination, move to injectables, which would basically be insulin. GLP-1, if they're on the GLP-1 already, you want to add a basal insulin to that. Optimally titrate your basal insulin, add your GLP-1, add your mealtime insulin. If you're refractory, add some oral agents onto that. So basically, you're kind of throwing the kitchen sink at the patient at this point. And you can really add these on. All the classes are different. The only one I probably wouldn't combine are the meglinides and sulfonylureas. Everything else is pretty much fair game to mix and match because they all do work slightly differently. So yeah, you could end up with somebody on insulin and on multiple oral regimens too, or multiple oral agents as well. So it's certainly not out of the realm of possibility. Ultimately, they go to a metformin plus basal plus like a mealtime or a GLP-1 type system, but that's kind of where they end their algorithm. All right, to quickly contrast that, so this is the AACE or Endocrinology Association group who recommends this. So they look at entry A1Cs and they basically tell you what to do. So again, they're more aggressive with their goals. So we don't do mono or dual therapy with ADA if that's what you're following until 9, and then they do it at 7.5 here. So a lot more patients based on their guidelines will qualify for that initial dual therapy. Again, much more aggressive, and you can see that in their goals too. They're more aggressive there. Monotherapy, this is in order of their preference, by the way. So monotherapy, metformin, and then you'd go down there. So they love GLPs in the Endocrine Society. So you can see that their dual therapy preferred is metformin plus a GLP-1. And you can see sulfonylureas all the way at the bottom. Here, they hate them, for lack of a better word. And you have the option of, so if your entry A1C is greater than 9, then you're looking at a couple of different things. So you could do triple therapy, which is metformin plus some of these agents as listed here. No symptoms, and your A1C is greater than 9, well then you could just maybe consider dual therapy or triple therapy, kind of like how aggressive you want to be. And then symptoms with greater than 9, insulin plus other agents could be considered too. So they're kind of telling you with this that if your patient's over 9%, you could consider you go straight to insulin if they're symptomatic. That might be a good way to do it. If they're kind of borderline, like symptomatic not, you can maybe try the triple therapy or dual therapy, depending on which way you want to go and how aggressive you want to be. So eventually, again, both the guidelines start at the same point and end at the same point. It's just the junk in the middle that they disagree on, which at the end of the day, I'm not going to test you on which guideline cares about which. What I want to test you on is the differences in the drugs. So. And every practitioner is going to have a different opinion on some of the advantages and disadvantages of these products. So, yeah. All right.
So forget the guidelines then, essentially?
I don't think it's worth forgetting. I think it's worth knowing because I don't think they're that much different, again, from the bookends of them. It's the middle stuff that's a little bit disoriented. But at the same time, it's about mixed and matching classes. So understanding how they sequentially add things, I think, is important. So if I gave you somebody on metformin and, I don't know, like a GLP, like where might you go from there based on what I would give you and what choices you would have? Like that. And then I'll just throw in this as a reminder, a lot of these drugs are expensive, so insurances may or may not pay for them, which is why I think AACE's recommendations are a little bit pie in the sky. They're like, oh yeah, just put them on a GLP and an SGLT. That's not always going to be covered by the majority of patients' insurances. So whether they can pay for those expensive drugs out of pocket or not, or whether they're going to have a really high copay, is a great question. That's why sulfonylureas still have some staying power, because they're really cheap and they're still pretty effective. So that's, I think, a lot of the debate we're seeing right now that doesn't come out in these guidelines. There is that cost factor that is important to consider too. I'm not going to test you on cost of drugs on this exam, but just something to think about for your practice. That I think it came out the first time that the SGLT inhibitors were out. One of the endocrine people came in and talked to you guys, was really in favor of them, and they just came out. They're kind of questionable about where they're even being used, and this person was like, oh, we should push them on like every young patient that comes in, and it's just like, yeah, but they're really pricey. That's the pushback there. They're super expensive, so got to take that into consideration with these. Anyway, just more of a pearl for practice if you go into primary care or do diabetic management.